So we have a first speaker, Dr. Anju. Dr. Prithvi is not ready. Mine is not uploaded. So can you start with your? So she'll talk on subretinal yellow spots, bleed or PD. Is it really AMD?
Once again, good morning. So, I'm going to talk about subretinal yellow spots, bleed or PED. Is it really AMD? So, why this topic is important, first of all? AMD is often the default diagnosis for any yellow lesion PED. Multiple conditions mimic AMD, which leads to misdiagnosis, unnecessary anti-VEGFs are given, and missed systemic disease. So, with this talk, my goal is to improve the accuracy using the multimodal imaging. So, there are two things. First is classic ARMD, next is mimickers of AMD. First, we'll see as a reference point how a classic AMD will look like. So, an elderly male present with soft drusen, fibrovascular PED, OCT will show CNVM, and FFA will have a classical leak. This case I am telling, which all of us know, just to establish the baseline to compare it with the mimickers. Next is mimickers of AMD. In mimickers, we have four categories. First is pachychoroid spectrum. Next is pattern dystrophies, inflammatory, infectious, and miscellaneous. First is pachychoroid spectrum. So, first one I'll discuss is PCV, a 56-year-old male with subretinal bleed, orange nodule, OCT showing notched PED, double layer sign, ICG showing polyps. So, clues against AMDs, thick choroid, polyp on ICG, no drusense. We will go to PCV. Next is CSR. Even the CSR is misdiagnosed. So, it is relatively younger patient with yellow precipitate, dome-shaped neurosensory detachment with serous PED, and FA will show, autofluorescence can show descending tracks, and FFA showing smokestack leak. The key point here is younger patient, serous PAD, often misdiagnosed as AMD. So next is pachychoroid neovasculopathy, younger 52-year-old with no drusen, type 1 CNVM, irregular shallow PEDs, choroidal thickening, double layer sign in OCT, neovascularization in octa. So learning point is no drusen, thick choroid plus CNV, consider a pachychoroid vasculopathy. Next is pattern dystrophies. So adult onset foveo-macular vitiliform dystrophy, a 60-year-old with vitiliform yellow lesion. FAF shows hyper autofluorescent ring. OCT will show vitiliform mold. How this mimics AMD is looks like drusenoid PEDs. That is how it becomes a mimicker of AMD. Next is best vitiliform dystrophy. A relatively younger person, around a 40-year-old male with smooth vitiliform subretinal mold, very bold, very bright hyperreflective autofluorescence, EOG abnormal, family history. It can be bilateral. So, key learning point here is relatively younger patient with vitiliform material. It's not an AMD. So, next is butterfly pattern dystrophy. Dystrophies are always bilateral. This will show a radial pattern, and tip is symmetrical pattern changes with dystrophy. It's not an ARMD. Next is inflammatory or infectious APM-PPE, a 40-year-old male, multiple yellow-white lesion, early block, late staining, OCT showing outer retinal hyperreflective layers. The clue here is younger, younger age, acute onset, and systemic prodrome. Next is under the inflammatory category, serpiginous choroiditis, peripapillary snake-like lesion, FAF showing advancing hyper autofluorescent stage, edges, OCT will show outer retinal loss. Message here is not all geographic atrophic pattern are ARMDs. So next is familial dominant drusen, which will also mimic like a geographic atrophy. Here it is bilateral and symmetrical. Always consider peripapillary radial drusen is not always ARMD. So next is mactal type 2. Yellowish parafoveal graying with temporal cavitations in OCT with parafoveal leakage in FFA. Tip here is inner retinal cavitations or not ARMD. Next is HCQ toxicity, which is very commonly seen now. For at least for screening, we are getting to see this. Parafoveal yellow spots. FAF shows bullseye pattern. This is visual fields correspondingly. And OCT will show outer retinal loss and advanced stages saucer sign. So positive medication history. Note drug toxicity frequently mimics dystrophy and ARMD. So based on all this, the summary is based on the age, if the patient is above 50 years, consider AMD, PCV and PNV, not always AMD. If the age is less than 50 years, CSR, dystrophies and consider inflammation also. OCT clues is serous PED, CSR, notched PCV, vitiliform mold, dystrophies, cavitations, mactal and saucer sign, HCQ toxicity. In FFA, rings lesion is there, vitiliform, bullseye, HCQ, and tracking lesion is tracking tract is there, CSR. And ICG, polyps, PCV, and pachyvessels, PNV. So from this topic, multimodal imaging is mandatory. Take home messages, not all yellow spots or PEDs are AMD. Most common mimickers are pachychoroid disease, vitiliform dystrophies, vitiliform dystrophies. FAF, ICGA and OCTA patterns give the diagnosis. Correct identification gives a correct treatment. Now always ask when we see a yellow lesion, is it really ARMD? Thank you.
Thank you, Dr. Anju. It was a great talk. So over to Dr. Prithvi. And he'll be talking to us on macular subretinal fluid, always CSE, think again. So the aim of this instruction course was a lot of similar conditions come to our OPD, common conditions, and we just wanted to have a differential on what else it could be. Some diseases mimic each other, some diseases are found coexistent together. So this IC will cover that. So over to you, Dr. Prithvi.
Thank you, Dr. Shishir, for having me here. I'll be talking about macular subretinal fluid. Uh, come. Yeah. Could it always be CSC or think again? So subretinal fluid at the macula, basically it's a separation due to the outer, between the outer blood retinal barrier disruption, causing choroidal hyperpermeability or accumulation in the suprachoroidal space. So basically, the first thought is always CSR. So choroidal. So it is basically a separation, like we said, outer blood retinal barrier disruption, causing choroidal hyperpermeability and accumulation of fluid over here. So what are the demography? That is typically it happens in men aged 20 to 55, associated with exogenous or endogenous corticosteroids, psychosocial stress, systemic sympathomimetic use, part of and it's a part of pachychoroid spectrum. And the mechanism which occurs here is choroidal hyperpermeability and venous congestion, causing RPE dysfunction and focal leakage, producing neurosensory detachment. So, symptom-wise, acute central blurred vision, micropsia, metamorphopsia, central scotoma could be seen. And in few cases, we can see even PEDs. So the best way of diagnosing this is with OCT. You get dome-shaped SRF, and FFA can be done. You can see ink blot and smokestack focal leaks. ICG is also a good modality for diagnosing CSR. So this is a fundus image taken from a smartphone. Basically, this is a CSR macular subretinal fluid. This is the FFA images seen over here, and this is the OCT showing the subretinal fluid. So what are the other causes of subretinal fluid? The next one is neovascular causes. It could be CNV, AMD, myopic CNV, and PCVs. So basically, it happens more in the elderly population, typically drusins and RP changes. In young, it can happen in the myopic age group, and then PCV more prevalent among the Asians and black patients, may present with the recurrent SRF and subretinal hemorrhage also. Mechanism is basically through breakthrough of neovascular membrane under RP or under neurosensory retina, leading to leakage. SRF occurs later, and then intraretinal fluid can also happen along with hemorrhage. Acute and subacute central visual distortion, metamorphopsia, and central scotoma, exactly like CSR. Examination points, you will find subretinal hemorrhage and PEDs in these kind of cases. Again, OCT, OCT angio, and FFA ICG can be taken. You can see the leakage in the FFA. Treatment goes again for anti-VEGF, but CSR we won't give anti-VEGF most of the cases. In this one, we give anti-VEGF, and you can see the regression also. So this is a image of CNV. You can see the subretinal hemorrhage over here, and you can see this subretinal fluid along with a small PED like with the hemorrhage over here. The next cause is retinal vascular leakage, mostly DME and RVOs. I'll go directly to the image. You can see over here. So this is the image of CSME, and then when we take OCT, you can see subretinal fluid, which is marked A, and intraretinal fluid also. So this is something which we won't get in the other CSC cases. And then we have the RVO. This is a macular RVO, and this also has intraretinal cystoid spaces along with subretinal fluid. So this is also can be differentiated by from CSC. Then we have inflammatory and infectious choroidopathies, VKH, multifocal choroiditis, TB, syphilis, posterior scleritis. VKH, we can see it happens mostly in the younger adults and are bilateral. So this is one differential point from CSC. And then mechanism, immune-mediated choroidal inflammation, breakdown of blood-retinal barrier, and widespread SRF occurs. And you can see bilateral diminution of vision, and patient will have pain, floaters, and subacute vision loss. And you can see in the examination also antichamber cells, vitreous cells, optic disc hyperemia if the inflammation is more, and choroidal folds also. So best way of doing this is a fundus imaging with the FFA will give you a good pinpoint leaks of VKH. You can see the starry sky appearance, and OCT will show you a lot of SRF pockets. So you over here, you can see over here there are a few SRF pockets which can be seen in both eyes, and which is demonstrated in the OCT also. This is a photo of multifocal choroiditis, which can also mimic CSC. And then we have posterior scleritis. It affects all ages, sometimes associated with the systemic and autoimmune disease. Scleral inflammation occurs, and it leads to choroidal secondary effusion and SRF. Severe periocular pain will occur, and patient will have decreased vision. And this can be elicited with the B scan. You can get the T sign. That's a fluid in the tendons capsule, which can be seen very clearly. And choroidal folds can occur. SRF and often ESR and CRP are elevated, and there will be intense pain. So this is a SRF of a posterior scleritis, which also looks like CSC. So that's what we need to differentiate with using a B scan, and also patient will have pain. So that is one of the major differentiating point over here. Then we have exudative detachment from systemic vascular diseases like malignant hypertension, preeclampsia. occurs patient with severely elevated BP, pregnant woman in preeclampsia, eclampsia, and HELP syndrome. What's the mechanism here is choroidal arteriolar ischemia, which causes RP necrosis and exudation leading to bullous bilateral serous detachment. And sudden bilateral vision loss occurs, and often with systemic signs like headache, seizures, very high BP, examination show Elsnick spots, and serous detachment. So again, investigation can be done, OCT, fundus photo, and this is a SRF fluid of a high elevated blood pressure patient, hypertensive patient. And then we have structural and anatomical causes, two of them, that is optic disc pit maculopathy and Best disease. Over here you can see there is a small disc pit which can be seen over here clearly. So that could cause extravasation of fluid to the macular area. So that causes the macular SRF. So this is one cause, optic disc maculopathy. Over here you can see how it looks very prominent and looks like a CSC, but then with the disc pit over here, you can see that it is because of optic disc pit maculopathy. And this is another image of Best disease. It also has a small CSC like SRF over here, and this occurs bilateral. And then we have neoplastic and infiltrative causes like choroidal metastasis and melanoma. Go to the image. This is a choroidal metastasis, which also has SRF, but you will see a lot of choroidal bumps over here that can be differentiated. And then choroidal melanoma, again, the same kind of subretinal fluid, but there is a choroidal bump, so you always have to note this point, differentiate. And the other causes could be, when I was just talking, there were macular holes, parafoveal macular holes, which causes subretinal fluid. That can also be a differential diagnosis. Yeah, thank you.
That was a good talk by Dr. Prithvi. Next, I call upon Dr. Shishir. He'll be talking about hemorrhages and exudate, diabetic retinopathy, or a diagnostic decoy. Over to you, Dr. Shishir.
Yeah, thank you, Doctor. So good morning, everyone. So my talk is on mimickers of diabetic retinopathy, and sometimes when DR comes to your clinic or some patients are referred to you as diabetic retinopathy for treatment, sometimes it's not exactly what it seems to be. So let's go on and see some cases. So this is a 50-year-old male, diabetic hypertension CKD. You can see this is how they're usually present in the late stage with these chronic hard exudates, like cluster of CSME in both eyes. So this is like a classic diabetic retinopathy in what you see, but now you're going to see some which present like this, but they're exactly not diabetic retinopathy. So this was a case, 57-year-old female, mild decreased vision in the right eye, diabetic hypertensive on medicines. Both eyes had mild NPDR. She had 6/9 vision in the right eye. Now, if you look at this fundus picture, you can see some exudation in that region, nasal to the optic disc, and there is also some like microaneurysm and some few hemorrhages, what you see there. But when you actually do the OCT, you can see there is a double layer sign with a small polypoidal lesion, but you see along with some hard exudates there. So this was basically polypoidal choroidal vasculopathy, a subtle one. And then when you do the OCT angiography, you can see this nice network just seen nasal to the disc in this patient. So this was not my moderate NPDR. This was referred as moderate NPDR, but this was actually PCV. And then you also on this other OCT, the deep slab, you can see this nice branched vascular network, what you see. And then post anti-VEGF and a shot of focal laser, patient improved back to 6/6 vision. So let's go to another case. This is case 2, proliferative diabetic retinopathy patient, 62-year-old male, DM, HT and CKD on a wheelchair, on dialysis 3 times a week. So he had 6/9 vision in both eyes. So in the right eye, you can see the classic changes of diabetic retinopathy, hard exudates, these hemorrhages, and also you can see some sclerosed vessels inferiorly. And in the left eye, those features are also there, but along with that, there is also a submacular or para submacular hemorrhage, what you can see, and like a small bump. So when we did the OCT through the fovea had subretinal fluid, and when you did the OCT through that bump or that area of the hemorrhage, you can see this small polypoidal lesion, what you see. So this was PDR along with that, patient had a PCV also in the left eye. So here the highlight is the OCT should not just be done through the fovea, but it should also be done along the full arcade. So you should get a raster scan, then only you will know exactly what is happening. And then this is post treatment with ILIA and a shot of focal laser to this extramacular PCV. You can see the SRF is gone. There is some non-center involving DME which is there, and this polyp has kind of scarred now. This is 4 months post treatment, and also along with that, he has undergone 3 sittings of panretinal photocoagulation in both eyes. What you can see in this wide field photograph. So let's go to the third case. So this was also again a patient, 55-year-old male, diabetic hypertensive, on dialysis twice a week. And you can see he also was referred for panretinal photocoagulation 3 sittings, and also advised anti-VEGF steroid injections because the nephrologist refused for giving a consent for the anti-VEGF. So he had referred to as DME with PDR in both eyes. So this is how it looks. Looks like CSME, you know, these yellowish spots there at the fovea there, and here also left eye also has these kind of yellowish kind of also fluid there in the left eye too. So this is the peripheral picture. Looks like a diabetic retinopathy, all hemorrhages, exudates. But when you do the OCT, you see this picture in the right eye, which looks like this long subretinal fluid along with precipitates in the subretinal space. This whitish color, what you see as subretinal precipitates along with, large amount of shallow fluid. This is in the right eye, and in the left eye, you see this like a DME fluid, but along with that, a large amount of subretinal fluid. So this did not look CSME or a DME to me. So I did the FFA. Now, when you do the FFA of the right eye, you can see there is a ink blot leak on just away from the macula there. So this was actually a chronic central serous retinopathy along with a diabetic retinopathy or a PDR. And when you do the FFA of the left eye, you really don't see any leakage. If it was a DME, you would have had these, dense leakage occurring right at the center there. But here you don't see much of a leakage. But in fact, you have an NV happening on top there. You can see this new vessel there. So this was PDR coexisting along with a central serous retinopathy, and he was treated with 3 sittings of PRP along with focal laser in the right eye and micropulse laser in the left eye, because there was no real point of leakage in the left eye. Anti-VEGF and steroid was not given in this patient. So let's go to case 4. So this was a 70-year-old male diabetic, female diabetic. Right eye was post vitrectomy for PDR with vitreous hemorrhage, and the vision in the right eye was 618, the left eye was 69. So here you can see these dense, again hard exudates there coming close to the fovea, what you see, and also in the left eye there is some amount of exudates along with hemorrhages, and both eyes were treated with 3 sittings of panretinal photocoagulation. And on top of the right eye was also post vitrectomy. But when you do, so she came with complaint of blurring in the right eye, and I thought it's probably a post vitrectomy DME, or still a DME is due to the diabetic retinopathy. But when you did the OCT, you can see she also has a shallow bump, that double layer sign on what you see, and along with the in the parafoveal region, she's got these exudates. So along with a PDR, she was also having a age-related macular degeneration or a type 1 macular neovascularization or a network there. So, and when you do the OCT, you can see this huge chronic large, new vessel, which what you can see in the right eye over there, and she was treated with anti-VEGF injections. So let's, another case, 50-year-old female diabetic, obese lady, 6 by 6 parts vision, both eyes, referred for moderate NPDR in both eyes. So you can see this lot of cotton wool spots all along the arcades, and also nasal to the macula there in the right eye, and then she's got a large cotton wool spot just close to the fovea in the left eye. Now when I dug down and asked the history, she had a history of snoring in the sleep and also waking up multiple times at night after sleeping. And this was the OCT in the right eye, no fluid, but you can see that cotton wool spot on the OCT there in the right eye, and another large one corresponding to the fundus photo in the left eye. So this was actually a retinal microvascular damage due to obstructive sleep apnea. So the obstructive sleep apnea can mimic diabetic retinopathy, presents with hemorrhages, cotton wool spots, sometimes dilated and tortuous veins, disc edema can be there, and also you can exacerbate if there is a diabetic retinopathy, can exacerbate the diabetic retinopathy too. So another case, a 50-year-old female, she came for a routine examination, 6 by 6 vision, both eyes. Somebody referred saying right eye has moderate NPDR and sent the patient. So she is diabetic and she also has mild NPDR in both eyes. You can see the few hemorrhages there in the left eye. The right eye also has hemorrhages and some exudates. But you can see this small bump over there, and when you do the OCT, you can see this small aneurysmal type lesion, what you see there. So she was actually referred for an anti-VEGF. There was no fluid. So here, this is like a RAM, like a mini RAM or a mini aneurysm. Sometimes can occur in diabetic patients. The small kind of aneurysms can be seen. And the treatment, if fluid is there, you can give anti-VEGF. With no fluid, along with the patients, this thing consent, you can go and do a small focal laser to this mini aneurysm. So the last case, 60-year-old male, diabetic hypertensive, right eye was 6/6 vision, left eye had counting fingers 3 meters. Again sent for CSME. So you can see the exudates at the macula in the left eye along with the sclerosed vessel there. So these hypertensive changes are seen. Along with that, moderate NPDR changes are also seen. But when you do this OCT, he doesn't have features of diabetic edema. Instead, he's got the subretinal fluid with these precipitates of what you see. So this looked like UVI tick to me, and when I did the workup, he was VDRL and TPHA positive. So this was a syphilitic placoid retinitis. So just finishing up. So some few of the mentions which I have not mentioned here, the common ones which you read in your books are hypertensive retinopathy, tributary vein occlusions, PVAC, radiation retinopathy, blood dyscrasias. These can all mimic diabetic retinopathy. Now, since I showed you that mini aneurysm, I'll just show you a PVAC too. This is how it looks. The PVAC. This is usually occurs in diabetics, or they may not be also having diabetic. They usually present with these small aneurysms of unknown cause, and they show usually a poor response to anti-VEGF and steroid. So the learnings are, you should be aware of the mimickers of diabetic retinopathy, DME, and aware of coexisting disease. So imaging as well as digging down the history is extremely important, and then treatment will be as appropriate. Thank you.
An excellent area of cases by Dr. Shishir. So next I call upon Dr. Risha. She'll be taking on a step-by-step diagnostic approach for yellow lesions in the fundus. Over to you, ma'am.
Thank you, Shishir. After all retina yellow lesions, I am going to show you some UVA conditions. Yeah, here there are some yellow lesions. Are they look same? Even though they look same, they are all of different etiologies. Some are infectious, some are non-infectious. So we will see one after another. See, these are all yellow spots, but not on the retina. They are all pars plana snowballs, part of intermediate uveitis. So whenever you see snowballs, look for causes of intermediate uveitis like TB and sarcoidosis and other rare causes also. See, these are all again yellow lesions, but these are retinal lesions. Full thickness retinal necrotic lesions extending from periphery. These are all acute retinal necrotic lesions, viral. Most of the time they present with extensive retinitis lesions, but in the third picture, early ARN also can be missed as a toxo lesion. So it should not be missed. So how to differentiate choroiditis from retinitis? See, the first picture is a choroiditis lesion, deep lesion, margins not well defined, yellowish. Vessels can be seen over it clearly. The second picture is retinitis lesion, margins are well defined, vessels not clearly seen over it, associated with vitritis over the lesion. OCT will help you in diagnosing the level of the lesion. And these are all yellow spots, toxoplasma retinochoroiditis with chyleriasis arteriolitis, with or without a previous scar lesion. See again yellow spots, but these are all superficial crops of retinitis associated with disc edema and vasculitis. Is typical of DUSN. live worm can be seen in some conditions, may not be there. So treatment is albendazole with systemic steroids. The lesion resolved completely after 6 weeks of treatment. Again, another yellow lesion in the macula, but looks deep retinal. See the FFA, there is disc edema again with vasculitis. OCT shows these deep retinal lesions with granular deposits. See, this is typical of syphilitic lesion. Patient was positive for VDRL and TPHA and treated with crystalline penicillin, and the lesions resolved completely. So coming more deeper, see yellow spots, multiple yellow spots in the posterior pole. As mentioned earlier, deep lesions, vessels seen clearly over it. OCT shows choroidal granulomas. These are all sarcoid choroidal nodules. Again, choroidal deposits, not very clear margins, diffuse leopard skin-like changes. In FFA, these granular deposits. OCT shows choroidal and deep retinal deposits. It's a case of primary intraocular lymphoma. Again, choroidal lesions appearing as yellow lesion in the posterior pole. The pattern is like a serpiginous pattern. The peculiar pattern is seen in serpiginous choroiditis. FFA shows early hypo and late hyper. Fundus autofluorescence will help in the identification of activity in serpiginous choroiditis. It is not autoimmune. See, this is not the previous serpiginous picture, but in separate lesions with vitritis. This is TB serpiginous like choroiditis. These are all multifocal lesions. Again, hypo to hyper in healed lesions, and in active lesions it could be iso to hyperfluorescence. This is the typical TB choroiditis. Again, in the posterior pole, a yellow lesion deep at the level of choroid, and after treatment, the lesion resolved completely. Again, yellow lesion due to TB, but this is not choroiditis, it's a choroidal abscess. So, how to identify the abscess in B scan hypo center. Again, yellow spots in the posterior pole, like our DUSN picture, but these are all at the level of choroid. Vessels are seen clearly over it. And in FFA, multiple hypo lesions in late picture coming to hyperfluorescent. These are APM PPE lesions. Similar looking lesions, but in the left eye, fundus look very normal in fundus picture. But see, in FFA, there are multiple lesions of punctate inner choroidopathy. Here comes the role of imaging. Again, multiple yellow lesions with fluid detachments. These are all VKH exudative RDs, multiple exudative RDs. FFA shows disc edema and fluid detachments. In late stages of VKH, these yellow spots known as Dahl and Fuchs nodules appear. These are all sub-RPE deposits. So, what this could be, again a yellow lesion. Patient was on Bactrim DS for toxoplasmosis, but no vitritis, no signs of any inflammation. So, we just did an FFA. See what it is. It's a fibrin CSR with CSR leak. After the same day, we did a laser, and the fluid completely resolved. See, this looks like a old choroiditis scar, but in Octa there shows an early CNVM. So this early inflammatory CNVM can be picked up by Octa. Again, yellow lesion, peripapillary with fluid detachment. It was looking like a posterior scleritis. So we initially we diagnosed it as nodular posterior scleritis and admitted the patient for systemic steroids. But no, after 2-3 days of IVMP, there was no improvement at all. So we did an MRI and they suggested PET scan and see what is there in PET scan. It was CA breast with the whole body metastasis, including choroidal mets. Again, peripapillary yellow lesions with disc edema in a 57-year-old smoker. We evaluated and found to have paraneoplastic optic neuropathy due to mucin secreting adenocarcinoma lung. Again, a choroidal nodule like our sarcoid nodule, but this patient was having a small cell carcinoma lung with choroidal metastasis. So these are the tips. Always identify the level of the lesion, whether it is at the level of retina, choroid, and identify whether it is only ocular or part of a systemic disease. And always rule out infection, masquerades. Imaging and lab investigations will help you in further management. Thank you.
Thank you, Dr. Risha. Very nice bunch of cases you showed with the yellow lesions. Next, we have Dr. Rahul, and he'll be talking to us on retinal pigmentation, benign finding or life-threatening clue.
Can I have a slide? So good morning, everyone. At the outset, I would like to thank Dr. Shishir for this, including me in this instruction course, and I'm happy to see so many audience still up even after the post-banquet. So I'll be talking about retinal pigmentation, a benign finding or a life-threatening clue. Now, suppose, why this topic? Now, suppose a patient's come to you, a toxoplasmosis affecting the macula, and you see the patient and you want the patient for a system, send the patient for systemic evaluation. When you tell this, convey this to the patient, it feels justified. The patient is ready to accept it. But many a times you see some lesions in the periphery and you don't know what to do. And sometimes it might be a sign for something very sinister. And that is how, when you send these patients out for a evaluation with a intensivist or a physician, that's when you should have a very good clue idea about what lesions you can just probably sit on it, and some lesions which require a detailed evaluation. So I'll be talking about certain lesions like that. So the first thing is congenital hypertrophy of the retinal pigment epithelium, that is CHRP. So it's basically a hematoma of the RP. There are three variants: the solitary form, the grouped, that is multifocal, and then you have the atypical and multiple. Now, in the subsequent slides, I'll tell you about what is the difference between multifocal and multiple CHRP. So this is solitary CHRP. These are usually appear as a flat, round, hyperpigmented lesion. They have a smooth margins. The usual size is around 100 microns, or it might be larger. They are well demarcated. The overlying retina and the vasculature is absolutely normal. They have a predilection to be for the superior temporal equatorial region, and this may enlarge over a period of time. These are group CHRP. These are also well demarcated round lesions. They are around 100 to 300 micron size. They are called as the bear track lesions. And when you look at these lesions, the size of these lesions will increase as you see. These are group ones, right? So from the mid periphery to the periphery, you will see that the size of the lesions will actually increase. And they are usually grouped in a bunch of 3 to 30. Now, when I talked about the multiple one and the group CHRP, how is it different? So in skin, there's there's something called as a line of Blaschka. That is, what happens is there's an embryological developmental of the skin. Just like similar to that, you have a embryological development of the RP, and that is why in the group CHRPs, the lesions will appear grouped in a particular segment. Now, when you look at the multiple CHRP, they might be haphazardly distributed anywhere over the fundus. So these ones are usually smaller than the solitary as well as the group CHRP. They will be around 50 to 100 microns in diameter. They will have retinal invasion. You will see glial or capillary or RP hypertrophy. And some of them may also appear as a typical shape, that is a pisciform one. pisciform one, that is the one in the top down right side of the picture. You can see a pisciform kind of CHRP, and they have meritonal orientation towards the optic disc. So why is CHRP important? Because most of this, when you see this atypical or multiple CHRPs, they are associated with the familial adenomatosis polyposis, that is FAP. So these are inherited, highly penetrant genetic condition. If a patient has familial adenomatosis polyposis, they have literally 100% risk of a colorectal cancer. And patients with a typical multiple CHRP, almost around 90% of these patients will have this FAP. Also, along with this, they are also associated with Turcot syndrome and Gardner syndrome. So, what is Turcot syndrome? That is, you have a familial adenomatous polyposis with the brain tumor lesions. So they have a higher risk of colorectal cancer, glioblastoma, medulloblastoma. There are two types. There's a type 1, which is germline mutation in the DNA mismatch repair genes, and in the type 2, you have a germline mutation in the APC gene, that is chromosome 5. And then you have the Gardner syndrome, where you have features of familial FAP with extracolonic manifestation, that they'll have higher risk of skull osteomas, thyroid cancers, fibromas, and desmoid tumors. So whenever you see patient with CHRP, that is a atypical, if you see a solitary CHRP or maybe a group CHRP, probably you can reassure the patient, but keep the patient on a follow-up. Whereas if you see multiple or atypical CHRP, refer the patient to a gastroenterologist. Not just a systemic problem. This is a case from Carol Shields, where you can see in the top left image, there's a patient of a solitary CHRP, which over a period of time developed a tumor, enlargement in size. And when they did an enucleation, it was found to be an adenocarcinoma of the choroid. And not just systemic issues, they can sometimes also be associated with a development of choroidal neovascular membrane. Next, this is congenital group alpinotic RP spots, that is CGARPs. So, just like the bare track appearance, that is the CHRP, which is pigmented black, this one will be white. So, these are called as polar bare tracks. They usually affect the peripheral retina, and usually the macula is spared, and it can be either unilateral or appear in both the eyes. So, in this image, you can see in the color picture to the left, you can see all these white spots, which probably most of us would have seen and probably not given a second thought to it. So nothing to you have not missed much. And if you get a autofluorescence for this image, you will see it as a hyper autofluorescence. So when you get an OCT through this lesions, you will see that the RP in that region is a little thickened, and you might sometimes see some RP excrescence. The vessels and everything overlying retina will be absolutely normal. So this is a completely benign lesions, and you don't need to hit the panic button. And then next you have the choroidal nevus. So they are basically benign melanocytic lesions of the posterior uvea, and you can have two variants. You can have the pigmented lesion, pigmented nevus, as you see in the left side, and you can have the amelanotic version. Now, if you see a nevus, okay, fine, keep a tab over it. But there are certain times this nevus can have a malignant transformation, that is into choroidal melanoma. So we usually have this mnemonic to find small ocular melanoma using helpful hints daily. So whenever you see, if the nevus has a thickness more than 2 mm, if there is a surrounding subretinal fluid, the patients come with symptoms of flashes or floaters. If you see orange pigments over the overlying nevus, then yes, you need to hit the panic button. If the margin is within 3 millimeters of the optic nerve head, on ultrasound it appears hollow. If there's a halo absent, if there's a peripheral halo, that means it's a sign of chronicity. And same way, if you see if you see a nevus with drusen, you can rest assured that it is a very chronic thing, and you don't need to worry much. And this is another important pigmentation that you can see, that is called as the leopard spot pigmentation. Dr. Risha had already shown one picture. So this is the picture that you usually get. You will see multiple white spots. The patient might have some amount of vitritis or something like that. The first thing is, what we tend to think is it is probably a case of uveitis. And as we know, most of the uveitic conditions, it's an inflammatory condition, and the treatment that is required is steroid. You have to really understand that there's a differential of a posterior vitreous PVRL, that is intraocular lymphoma, which also appears similar to like this. And what happens is, when you give steroid and you take a biopsy from this lesion, the biopsy, because we have had seen a case in during my fellowship where a patient was treated as uveitis. Finally, it turned out to be leopard skin pigmentation, PVRL. And what happens is when with the steroid, the biopsy comes negative. And as long as you have the tissue negative, the oncologist will not start the treatment for that. So finally, it ended. We had to stop the steroid treatment, wait for a couple of months, and then take up the patient for a biopsy. And only then the biopsy, treatment for lymphoma was started. So you should have a good idea about all the differentials of these pigmentations. So my take-home message would be: not all pigmented lesions are dangerous. A good knowledge about them is very essential. Reassure, but never keep them out of sight. And if you see an atypical multiple CHRP, refer the patient to a gastroenterologist. Thank you.
Thank you, Dr. Rahul, for that talk on all the retinal pigmentation. So, any questions from the audience on all these talks? So, we talked about CSE, talked about AMD, all the hemorrhages, diabetic retinopathy, talked about uveitic conditions and also some pigmentation. So, any doubts from the audience? So, also talked about a lot of mimickers which can happen and coexisting disease, how to differentiate between both of them. Nobody? Okay. So, one question for Dr. Risha actually, since uveitis is one of my weak, this thing. When you see a patient with a yellow lesion in the fundus, what based on the view, what investigation will you order? Ocular investigation, imaging, as well as this blood investigations as a baseline, because there's a lot of this thing baseline uveitic workup. What all would you do, like for posterior uveitis?
Yeah, thank you, Shishir. Unlike other ocular subspecialties, I think uveitis case, whenever you see, you sit with the patient for some time. You try to see what is that lesion, whether it is, as I mentioned, no, whether it is in the vitreous, whether it is in the retina, whether it is retinocoroiditis, whether it is only choroidal, whether it is not associated with any inflammations like masquerades. And after seeing that lesion for quite some time, no, we should we should cut short our provisional diagnosis. Like it could be this, it could be that, and based on that, you do first line investigations, imaging and blood investigations. You can't order for all the battery of investigations for all uveitis patients. So based on that, whenever you see a suspected case of toxo, okay, no need of any more imaging. Just take a fundus photo and then order for routine investigations, Manjo and toxo, IgG, IgM, and start on Bactrim DS. Tell the patient about the possibility of sulfa allergy. Call the patient on the third day. Ensure that there is no sulfa allergy. Manjo is negative. Start on steroids along with, like that. And whenever you see the patient the next day, again see that patient completely as if you are seeing that patient for the first time. Talk to him and see the patient thoroughly, including fundus periphery, so that and whenever the response to the initial treatment is not as good as you expected, then also do more investigations and do more imaging. That is my dictum.
Do we take physician fitness before starting oral steroids?
Usually, no.
Usually.
I do routine investigations, Mando before
Serology
starting.
is done before starting.
And
for all patients.
rule out diabetes also. For systemic steroids, I routinely not taking physician fitness, but for immunosuppression, I do.
And do we take consent before giving Bactrim DS to the children?
Not taking any written consent, but I always write in the file that there is no sulfa allergy reported so far, and there is no family history of sulfa allergy also.
Okay.
And in toxo case, ma'am, when would you prefer intravital
If
fluid?
it is close to macula threatening lesions, if the clinical picture is very much similar, the same day or the third day when patient comes with the investigations, and the first injection I give only Clinda, and after 1 week Clinda plus Dexa. Maximum 3 injections, the lesion
While
usually
we give
resolves completely.
clindamycin also, do we, I mean, the patient will be on oral steroids and Bactrim DS also? Or we will wait?
If patient is allergic to Bactrim and all, then usually only intravitreal. I used to treat both way, depending upon the clinical condition and
Scenarios.
general condition of the patient. Some patients give both.
Thank you, ma'am. So I think another 1 more minute for discussion. I just ask one question to Dr. Rahul. So you also discussed about that pigmentation. So let's say a asymptomatic patient comes for a routine exam and then you see one CHRP lesion in the periphery. First question, do you tell the patient that something is there? Second, if once you tell, when would you ask them to come for a repeat exam?
So, first of all, if I see a pigmentation, like I said, if it is a solitary lesion, you can just tell the patient that you have some pigmentation in the retina, nothing to be worried about it. Probably an annual eye examiner should be more than enough. But if you have all this, the red flag signs, like I said, the group ones, no, sorry, the multiple ones or the atypical ones, then probably it depends. I'm like, the patient what comes, if the patient is for a routine checkup, it might be sound to actually tell the patient that you have a condition and probably keep a shorter follow up or maybe directly because see this is a genetic condition. This is like the patient is born with it, so maybe the patient would have come to you at the age of 30 or 35. Maybe a delay of 2 or 3 months should not be worse. So you can probably ask the patient ki, like probably we'll see you in 2 to 3 months time and again and see whether it's worsening or not, and at that time probably I might ask for a repeat checkup. Sorry, I might refer to the patient.
So any questions from the audience? If no questions, then we'll close the session. Thank you.